Welcome to the Ticktective podcast and video series, a program of the Bay Area Lyme Foundation, where our mission is to make Lyme disease easy to diagnose and simple to cure. I'm your host, Leah Gertner, Director of Education and Outreach. Lyme disease is the most common vector-borne disease in the USA and is a global issue. This show includes interviews with the researchers we fund, as well as other interesting people in the Lyme scientific community. We are a nonprofit foundation based in Silicon Valley. Thanks to a generous grant that covers all of our overhead, 100% of all donations go directly to support research and prevention programs. You can find out more or donate at bayarealyme.org. Welcome to the Ticktective podcast and video series, Dr. Stephen Phillips.
Thank you for having me, Leah.
Stephen Phillips is a Yale-trained physician who has treated over 20,000 patients from over 20 countries. He is acclaimed for his work in linking chronic diseases to infections and successfully treating some of medicine's most complex cases. Dr. Phillips went on to co-author the book Chronic with another one of our past Ticktective interviewees, Dana Parrish, who was Stephen's patient. The popular 2021 book examines evidence that a broad range of common infections from COVID-19 to Lyme disease and many others can cause a variety of autoimmune, psychiatric, and chronic conditions. In 2018, Dr. Phillips was awarded the Bay Area Lyme Foundation's Emerging Leader Award to work on a novel therapeutic strategy in collaboration with Duke University researchers. Lastly, Dr. Phillips also serves on the Bay Area Lyme Foundation Scientific Advisory Board. So, your book, Chronic, addresses a wide range of complex scientific, social, political, and economic issues around autoimmune and infectious diseases. The book is what I consider, and I know I heard Dr. Bean interview you, we all consider it a rare gem that I think boldly covers some rarely discussed truths about medicine, biology, business, and politics.
Well, thank you.
To start, I just wanted to know if you can tell our listeners, what do you find to be some of the most important take-home points from the book Chronic?
I think one of the most take-home points is that you have to have a team effort with a physician and other healthcare providers that what they say makes sense to you. Did you ever go to an attorney and they use really big words and you walk out of there like, I have no idea what that person just said? If a doctor is talking down to you or is trying purposely to use medical terminology you don't understand, if you ask questions, the person's too busy or deflects, it's like a learned skill. People think that, they have a doctor and there's a lot of, I'm not saying to be disloyal to a doctor or anything like this, but it's a partnership. Like the Marcus Welby days of like the doctor on the pedestal and the patient down here are gone. And that's one thing that patients who are chronically ill, I think, need to know within their hearts, like truly know that they're in control of their whole lives, in their own lives, and their own, their own advocacy. And they have to find a team that can help them and not stick with doctors who are not willing to investigate the tough cases. It takes a bit of a village to get some very sick people better.
You were already an internationally renowned physician specializing in complex chronic diseases when you became a bedbound patient yourself.
As embarrassing as that is, yes. So you got to think that if it happened to me, what chance does the average person have? And I went to 25 doctors, including 4 of the big Lyme doctors in the United States that we don't talk about in the book, because the fact is they couldn't help me. And there was really nothing known about Bartonella back in 2010. Everybody knew it's like an emerging infectious disease. They kind of discounted it. And we really considered Lyme to be the single big gorilla on the block. I know I mixed my metaphors, but it almost killed me. I didn't walk for 2 years. And I took a year and a half of antibiotics, 9 months of which were IV, that all failed before I kind of put the pieces together and figured out the best solution for myself. And that's when I got well, in a nutshell. So.
And then your father developed cardiac issues and was scheduled for a heart transplant, and you decided that you were going to investigate if there were any other options before it went that far, and you ended up curing your father.
This was before I started practice, and my dad had aseptic meningitis in the 70s, which frequently Lyme causes an aseptic meningitis, but nobody really knew anything. It just said it was a virus back then. And right after that, it was within a few months, he started getting heart palpitations that the doctors said were benign. And they were benign for many, many years. They were just, these crazy heart palpitations, nobody knew. And then it was atrial fibrillation. And then it got worse with time. It eventually developed chronic AFib and then heart failure. And we took him to the top cardiologist at the top universities in New York City, grew up just outside the city. And famous cardiologists, and they all failed him with the best medicines available. And he went into progressive heart failure. And I was just finishing up research, in Lyme. I was residency was at Yale, and I was doing Lyme research, and I was like, wow, Lyme can cause dilated cardiomyopathy, which is what my dad had. I went to his cardiologist and I said, do you think this could be an issue? Maybe we should test him. Maybe we should treat him. And he said, no, we're not going to do either of those things. He doesn't have, Bell's palsy. He doesn't have arthritis. I was like, why are you going by the stereotypes? That this can happen. Why would you rather do something that's so risky like a heart transplant before even trying? And it ended up falling to me, and I had to treat him. And the long and short story is that he did get fully well. His heart function fully recovered, and he never was in heart failure after that. And he went on to live another, 25 years, and passed away of a heart attack in May.
I'm sorry to hear that.
Yeah, thanks.
You've interviewed with a lot of other people and provided so much information. And I was thinking about a question I could ask that hasn't already been asked to you on Dr. Oz or Dr. Bean or whatever. And I was thinking, what is it about you or your history, your personality that makes you keep investigating and persisting when most people won't or don't?
Oh, I was just thinking about this the other day. I think I'm diagnosing myself with oppositional defiant disorder. I must have that. I mean, not to the point of being annoying to people, but in the point of questioning everything. And COVID's I think is a perfect example, because right away, there was such stuff it was counterintuitive, for a lot of people, the messages that we're hearing from like public health authorities, but it's really counter science. And I can get, granular with all those things. But I went down the rabbit hole with COVID like I did with Lyme, and I realized that, because I really thought that Lyme and vector-borne illnesses were like the one big lie in medicine. And I thought everything else was nice and clean and sparkly. And now I'm very suspect of the whole thing. If they can, sit by away, so many countless lives have been lost, and so many people have now developed chronic illness with long COVID, which I think many of these cases are unnecessary. The failure to it's the abuse of authority, really, in favor of profits over patients. So when I see this type of injustice, I keep digging and digging and digging, and that's what I do. And I don't. If anything that you learn from a chronic life-threatening illness is you don't get to crap from anybody. It's like life's too short. So if doctors went to med school to just kind of toe the line and keep their head down and not speak the truth to the patients, maybe they should have chosen a different job.
So in your book, you wrote this about autoimmune disease. In 2017, it was estimated that there were 50 million people suffering from autoimmune diseases in the US, which is 20% of the population, or 1 in 5 people. One of the most popular immunosuppressants, Humira, has sold upwards of 130 billion since 2010. Enbrel garners Pfizer and Amgen nearly $5 billion in revenue annually. I don't know if this is all outdated, but it's probably still in line with that. So what do you think would incentivize the US government, corporations, philanthropists, researchers to invest more into what may trigger things like autoimmune diseases? And we know what triggers long COVID. We just don't understand the mechanism fully, but just maybe stick with autoimmune diseases for now.
Right.
Why do you think that when you get diagnosed with an autoimmune disease, generally the doctor will say it's unknown etiology, meaning we don't know what causes the body to attack itself? I know that there's some literature around gluten causing autoimmune diseases, something your body wants to get rid of, tick-borne pathogens causing autoimmune diseases, and now huge headlines that Epstein-Barr can trigger multiple sclerosis, which is something that I know in the Lyme world has been talked about for decades. And I know there's some studies going back, I think even a century, looking at stuff like this. If we do know some of the potential triggers, why aren't people in the medical community acknowledging them and treating them?
Okay, the stuff that goes back a century is probably referring to spirochetes with MS, because that goes back a century. I don't know that Epstein-Barr would go back that far. So it's a big question. In terms of financial incentivization, there's really not much money in cures compared to money in suppressive treatments. And these immunosuppressants are annuities for pharmaceutical companies, because patients get doled out a degree of decreased suffering. And then when the immunosuppressants wear off, the suffering comes back and they have to get their next kind of fix. So hepatitis C is a perfect example. Hepatitis C therapy, they made like wild advances in cure. and the company that came out with the treatment. And there were several companies that came out with these curative treatments. And the pool of hepatitis C patients continued to decrease. And they had these business analyses that came out in different magazines. It was actually one that was published in a peer-reviewed medical journal. That's not a good business model. You know, it's really not financially incentivized to cure patients because, you know, you don't have them coming back and back and back. So how to re-incentivize them, I'm not sure what the best way would be, because the biologic industry, I think last time I checked, it was valued in the biologic immunosuppressants I'm talking about, it's close to $1 trillion market. So that's a lot of money to walk away from. And to try and investigate cures, why would they be incentivized to do that? They wouldn't be. In terms of doctors and what doctors say, you know, this is the way it is. Most doctors, you know, like primary care doctors, seeing 30 patients, 40 patients sometimes in a day. I spoke to a primary care doctor the other day. He said that if he didn't have the picture of the patients pop up now on his laptop, he wouldn't know who anyone is. It's like there's not even any time to go into anything except for the basics of the appointment. And they're not going to be looking, like I said, down these rabbit holes to find the cause. It's much easier just to go with the flow. And it's been very much kind of hierarchical. That's how medicine is. It's a very different way to think, really. Like, you know, I went to Penn at Wharton, and they teach you how to think, and then medicine teaches you what to think. And I think that that's not the way that doctors should be trained. I think there should be some changes in how doctors are trained. So we should learn to question things more, because you know, I know a lot of doctors that don't change their practice over a period of 30 years of medical practice. And they keep up with, let's say, whatever guidelines come down from their large organization and change their blood pressure medicines accordingly and this and that. But the big topics, like looking for causes of major chronic illness, it's really like not something a doctor can do unless they have a unique structure to their practice or their researchers.
I know a lot of the more recent studies come out in the forms of advertising from novel pharmaceuticals. And so they'll teach doctors through advertising and patients about new discoveries in terms of like fibromyalgia. Maybe you can tell the story about fibromyalgia. It's an interesting one.
Sure. So I'll just comment on the EBV data with Epstein-Barr. I mean, there's an interaction with EBV and Lyme, for example. It's published that when Lyme enters a cell infected with EBV, it induces a replication of the EBV. It goes out of its latent state into a replicative state. So there's sometimes an oversimplification, like, wow, we found EBV. They also had found coronaviruses in tissue from MS patients. You know, in tissues of disease, viruses can replicate. The data with spirochetes linking to MS have been going down. That's literally been 100 years going back. And they've done multiple animal studies where they've taken spinal fluid and brain tissue from MS patients and put them into animals and shown the animals got progressive neurologic illness. In some cases, they found spirochetes from those animals. They have done several open label trials treating MS patients with antibiotics of tetracycline class and showed that their functional stores increased, there's less shrinkage of the brain, there's less lesion count. And these are small studies, and no one's really incentivized to do larger, like randomized controlled trials for antibiotics in MS. But I can tell you, for relapsing MS, my response rates are excellent. They've been excellent since I started. And I used to talk about MS all the time. I used to give lectures on it. And there was a time that my practice was half MS, and I just kind of shut up about MS because I wanted to be more balanced patient population. But primary progressive MS is a different story. They don't respond very well. It's not the same. Relapsing MS responds much better to antibiotics generally. In terms of fibromyalgia, as a condition, there are links to infections. Like, they published a study a long time ago where they looked at patients who had CDC positive for Lyme and showed how they then went on to develop American College Rheumatology criteria for fibromyalgia, which is the points they have to press and the pain and everything. And then they did muscle biopsies of the patients, and they found that they could prove, most of them harbored B. Lyme DNA in the muscles. So yes, they met the criteria for fibromyalgia, but people have to understand that these rheumatology diagnoses, which are purely descriptive, were around way before Lyme was even discovered. So they had all these descriptive diagnoses, whether it's rheumatoid arthritis, lupus, fibromyalgia, multiple sclerosis. And I'm not saying Lyme causes all of them, I'm not saying infections even cause all of them, but I think that infections cause many of them, because otherwise we wouldn't have the response rates that we do, which is in the very high 90s across the board. And my diagnoses were ankylosing spondylitis and rheumatoid arthritis. And I was the poster child for rheumatic illness. And I went back to my 3 rheumatologists and told them about how I got better. And they each reacted in really different ways, which displays how, like, our humanity, changes how we practice medicine. Like, one was complete, like, adamant disbelief. How could it be? And did this full neuro exam, looked at my labs, and kind of begrudgingly was like, okay. The other one was like overjoyed, so happy. She's like, wow, I can't believe you did it. You got yourself out of disability. I was like, is this going to change how you practice? She's like, hey, what am I going to do? I can't change. I've been doing this 30 years. You expect me to, like, change everything and treat with antibiotics? I'm like, yeah, I do. I expect you to look into it, And so that's that story. But fibromyalgia as a disease entity, responds, in my experience, very easily to antibiotic therapy if we find evidence of infectious, underlying infectious illness. Yeah, I'm all about the cause. I think that it's prudent to treat effects for a period of time, but you don't want to just treat symptoms throughout somebody's life. We don't want people to suffer. Like, when I was at my worst, I couldn't believe how much pain, like, the human body could make. I could not believe the amount of pain that I was in. And if I didn't have pain doctors at the time, I didn't know what I would do. But I wouldn't want to have been zonked up on pain meds the whole time and just live my life that way. I, would want to do something, which I did do, to take the edge off while I was still in my pursuit to get better, but not just treat the symptoms.
In terms of tick-borne diseases, I know you had Lyme disease, and then you recovered, and then you had the episode with Bartonella later. What percentage of your patients do you find end up with some kind of tick-borne disease, including Bartonella?
Well, most of my patients, it's a practice. I have one of the largest practices in the country that specializes in solely vector-borne chronic infections. So most of my patients have come in with a diagnosis already, and I've seen multiple doctors. So it's nearly 100%. There are some patients that come in with just mysterious symptoms and say, please make a diagnosis. And we've had patients where didn't think it was, vector-borne infection. Clearly, I've had patients come in with metastatic cancer and said, and it's the hardest thing, I'm sorry, I know you really want to be diagnosed with Lyme, and said, no, you have pancreatic cancer. I've seen that. So, but I've also seen people come in with congenital problems. I've seen some patients. I remember someone came with progressive genetic neurologic condition, which was not vector-borne related, and he'd spend like close to $1 million out of pocket through an academic system. Even after that, was just his copays were like close to $1 million, and he had he brought in a cart of boxes, like a legal thing, like stacked up, like you're moving, 4 of them, and just hundreds and hundreds of pages of medical documents. And I must have been like, oh, like this. And he's like, is that okay? And I was like, yeah, no, it'll take me a while to get through it. He's like, oh, good, I'll get the other carts in the car. And he had 2 of those big carts, and it took me about 3 months to get through his medical record. And at the end of the day, I didn't think it was Lyme related. I think it was something called Charcot-Marie tooth, like a weird variant of a genetic neurologic condition. So we see it, but most of the patients are vetted so well before they come in, because they've seen so many doctors. Everything's been ruled out. I when people say I'm the doctor of last resort, because it puts so much pressure on me, but I hear that all the time. When people have seen 25 doctors, most of the people that get diagnosed with, tuberculosis or whatever, something that's easy to diagnose, they don't look outstanding.
And I know from personal experience, as do you in your story, you talk about it in your book, it's hard to treat everyone the same, because even the people who have the same pathogens are going to have different symptoms. It's going to affect their bodies differently. And so you can't just give everyone a week of this or 2 weeks of that.
Yeah.
It's a bit of science and an art, because you have to sort of see what works and what doesn't, and trial and error. And how many roads do you feel like on average you have to go down trying this treatment or that treatment? First, you try to identify the pathogens, the systemic influences that are making the person sick. How often do you go down one road and then decide you're going to try something else?
Well, we frequently go down roads and then switch, but it also depends on how treatment naive or treatment, non-naive the person is. Because if someone is treatment naive, chances are, let's say a new person hasn't been diagnosed, which is like a relatively rare in my practice, but those patients usually respond much easier than somebody that has been diagnosed with vector-borne illness and either has had a lack of response to half the medicines out there, or a response where they flare up terribly with Alzheimer's that can't be tolerated and have a lot of other associated immunologic problems like severe mast cell activation, things like this. So I would say it really it very much depends on the patient that way. But in a treatment naive patient, they're usually much easier to treat because they're not a subselected population of the hardest of the hard to treat. Of the hardest of the hard to treat, in a way, you don't have to go down as many roads because some of them are failures. Sometimes though, when I look back to the patient's histories, things that were discounted as failures, they haven't been given what I call like the fair shake and the expiration date.
As a chronic disease expert, I guess long COVID kind of falls right in your wheelhouse. There aren't a lot of other areas of medicine where I can imagine a physician has had so much experience with mysterious, unresearched, under-researched chronic diseases. So I know that a lot of these Lyme literate doctors are trying their best to help people with long COVID, just because these doctors are people who are, like you said, a little willing to go out on the edge and maybe more willing to believe somebody with subjective findings. Maybe their lab tests look fine, maybe they look fine on the outside, but they are complaining about things that can't be seen, which is something you're used to.
Right.
How are you approaching long COVID in your patients?
So my nurse practitioners are seeing long COVID patients. I've only had a couple. Treated about 200 COVID patients, and I've been offering patients early treatment from the beginning. And there's a whole range of things that have made sense. And my patients have done well. I mean, with alpha strain, we didn't have anybody that I treated with alpha develop long COVID. I had one long COVID patient at the time who was not treated. She didn't call me, and she actually did respond just to ivermectin, and it went away, and then it relapsed and went away again and didn't come back after that. And then with Delta, we have one person who came to see me like close to 6 days in, and she developed long COVID and had to get oxygen she had a severe case and had to get oxygen for a while. And she slowly resolved her long COVID after like 3 to 4 months. And with her, it really seemed like it was damaged to lungs. It was just slowly resolving, like lining of blood vessel damage. And then these other, the more mysterious cases are when people get mild cases and then they get chronic symptoms like a month later. That's very reminiscent of what I've been seeing for years before COVID ever came about, because some of my patients, their histories aren't that, oh, I had a tick bite and then a rash and then a Bell's palsy and I got chronically ill. A lot of the patients I had a flu, or I had dengue fever, I had really bad mono, and I've been sick ever since. And that's how a lot of like the chronic fatigue literature demonstrates, where it starts kind of like the viral illness. The question is it the persistence of the virus? Is it the persistence of the virus, plus something else, or is it something else? And that something else could be asymptomatic or minimally symptomatic other infections, like things like Lyme. And we have a number of patients now that we're going to write up some reports, I think, and try to get them published, because these people were diagnosed with long COVID. And, the symptom list of long COVID and chronic Lyme overlaps like 95%. And these are people who tested positive for underlying Bartonella and Lyme. And it was like pulling the thorn out of a lion's paw. People who've been sick for months and months and months, been told these doctors, long COVID, long COVID, long COVID, and get Alzheimer's and antibiotics, then get better. So I think that long COVID patients should be evaluated for the potential presence of occult infections that could be treatable. And of course, they should be also evaluated as best as they could for the persistence of the virus. So how do we even do that? There aren't good tests, but what you could do is look for clotting dynamics, things like D-dimers. I'm not saying that some people don't have just elevated D-dimers anyway without COVID. And some people certainly with genetic clotting disorders have elevated, and the D-dimer, again, is a marker of clotting. But I think that we should pursue the targets that make most sense. And it's like the low-hanging fruit. And if you find a few bands in a Western blot, or if you find some Bartonella reactivity in patients who are chronically ill, even if they have a diagnosis of long COVID, it's been our experience that we've gotten many of these patients better.
How much research, I know we're at the very early stages, but is there research showing that long COVID could be like Lyme disease could possibly be a persistent infection, that the virus stays longer than people think or longer than we test positive for?
Definitely. So the viruses, doctors and people, regular people too, we tend to think of viruses as either acute or chronic and put everything into little boxes so it's easier for us to kind of understand things around us. And it's not really true. Even regular seasonal coronaviruses have been found in tissues in the brain, like I happened to mention before. And with COVID, with coronavirus that causes COVID, they've found evidence of active replication months into the illness. They found, active virus in the olfactory bulb with patients. They found virus in GI sampling during colonoscopies, and autopsy sampling. They found evidence of the virus up to like 8 months throughout the body. So whether these viral particles are alive, actively replicating, if they're dead pieces, sometimes they're hard to tell, but the body gets rid of dead foreign matter pretty quickly. It doesn't just stick around in the body. Our immune systems gobble that stuff up. I think a perfect case example of, I don't know if you ever heard of this, but they had this write up a while back, many years ago, a few decades ago, a group of researchers down in Antarctica. And they were down there for a long time, spending the winter with like completely isolated. And I don't know how many weeks or months they were down there, but a while, and one by one, like half of them came down with an upper respiratory virus. And where did they get it from? Was it just hiding out latent in one of them? And it's kind of this in-between phase, neither chronic nor acute. And there's even evidence with influenza that children can carry influenza in their tonsils. And people don't think of any chronicity to influenza A, but that can happen as well. So I think these viruses are kind of gray and not black and white.
Well, you have the herpes viruses and the chickenpox virus, right? Those will stay with you for latent.
Right, and those are the ones that people, that's a stereotype. So everyone knows that herpes viruses are chronic. Everyone knows that HIV is chronic. They're accepted, but they're not accepted. And then the other ones are considered acute, and they don't think they're going to stick around. And they're including coronavirus in that, even though there's been all this evidence before COVID ever came around that there's been evidence of persistent seasonal coronaviruses as well. So I just don't think that the acute viruses are really that acute. Like measles, most people don't think that measles sticks around, but there's a well-known late neurologic syndrome that can kill people that's related to persistent measles in the body. So I'm just not sure. I think very strongly that the possibility and the likelihood of some persistent virus driving some cases of COVID is very, very real. I also think that the likelihood is that it's upsetting the apple cart. It's causing some cases of previously occult infection with things like Lyme and Bartonella and others to become symptomatic, because we've seen that in the office.
And how do you think Lyme, with all the studies that just came out about Epstein-Barr and multiple sclerosis, I know that Lyme might be one of the missing pieces, right? Because the way that I understood it, 95% of people carry Epstein-Barr virus, and a small percentage will go on to develop multiple sclerosis, but you can't develop multiple sclerosis unless you have Epstein-Barr. And so what is the connection between the two? And I know that some people are saying, well, maybe there's something like, another infectious agent that is suppressing the immune system enough that Epstein-Barr gets a hold and can cause things like multiple sclerosis. What do you think the mechanism might be with something like Lyme disease as a third party?
So there's data, there's a few things. There's data that Lyme can cause a latent Epstein-Barr to start replicating within cells, that we know is an interaction. I'm not so sure that it's going to be 100% cut and dry. Part of the problem is that it's so ubiquitous. So many people do have Epstein-Barr. It's hard to say for certainty, but I'm sure they'll find situations in patients where they have not had Epstein-Barr and gotten MS. But I could just tell you that in all the years of treating relapsing MS, my response rates have been in the high 90s throughout, and I've gotten people off disability and out of wheelchairs and all these things. And primary progressive MS is a different story. It's a very hard condition. And as a group, it's very hard to treat. Not to say we haven't gotten any of those folks better, but I don't think that spirochetes per se are necessarily the cause of infection, because they do respond with Herxheimer's, but they almost respond like ALS patients, where they'll kind of flare up and they don't settle down. whereas relapsing remitting MS patients typically flare up and settle down, and we can get them to improve the large majority of the time. Again, that's assuming that we can find an infectious etiology for these conditions. There's going to be a lot of things that are, it's like the top of a pyramid, that could be, neurodegenerative can happen from so many things. Did you ever hear about how Guam had like 100 times higher rate of neurodegenerative illness? Okay, so they sent this guy to go investigate it, and they found that people were eating these fruit bats, and the fruit bats were having in them this toxin from this cyanobacteria, which is also a misnomer. They call it blue-green algae. It was living in the roots of the trees, or the fruit trees, and then they did a few research experiments. They did experiments in animals where they gave this toxin from the cyanobacteria to the animals. The animals developed the same brain changes that the people in Guam did. And they showed that L-serine can displace the toxin kind of from its mode of activity, its binding sites, I guess, and kind of counteract the effects of this. And they did studies linking clusters of neurodegenerative illness with outbreaks of blue-green algae blooms. Again, they're not really algae, it's cyanobacteria, but they're called blue-green algae just colloquially. And they corresponded to clusters of things like Alzheimer's throughout the United States. So clearly not an infectious etiology. So there could be neurotoxic environmental situations. There's this big lawsuit going on with some pesticides that are related to Parkinson's, also not infectious etiology. I don't want it to sound like infections cause every chronic illness, but it's equally incorrect to like blanket statement, not evaluate them to the extreme, because we're dealing with, in many cases, life and death. And in the cases where it's not life or death, it's the difference between like disability and full ability. Like I went from completely bedbound, requiring 24-hour home care, couldn't turn over in bed on my own, couldn't sit up on my own, couldn't get to the bathroom. I saw what it was like to be a 90-year-old man in a nursing home. And I went from that to a full life. So, people should know the choices that they have before them.
Do you want to talk a little bit about the infectious theories around Alzheimer's and ALS and Parkinson's and neurodegenerative diseases?
Sure. So Harvard did work, I think in 2016, and there's been decades of work leading up to this. The first person to find the presence of Lyme bacteria, Bubdiferi, and Alzheimer's was Alan McDonald, and he published it, I think, like close to, 25 years ago or something. And then other people like have found similar type findings, but it's largely gone ignored. And then Harvard did a study where they took salmonella and they put it into the brains of mice, and the mice developed amyloid in response to the brain infection. And they showed that amyloid is actually an antimicrobial peptide. So mice that don't have the ability to make amyloid, they genetically breed mice that can't make amyloid. If you give them a brain infection with bacteria, they die rapidly. So amyloid is definitely protective in youth and allows these mice to get older so the mice can have babies. And that's why amyloid is in existence. That's why it's such a highly conserved, genetic trait. And alpha-synuclein, which is the marker for Parkinson's and things like Lewy body dementia, that actually they've done similar studies with mice where they will succumb and die to a viral infection if they genetically can't make alpha-synuclein. So again, amyloid is the primary aberrant protein with Alzheimer's, alpha-synuclein the primary one for Parkinson's and associated syndromes, and then TDP43 is the primary aberrant protein associated with ALS and frontotemporal lobe dementia, which are actually spectrum illnesses. They're actually overlap. They're the same process. And some people develop mainly motor, some people develop mainly dementia. And there's preliminary evidence that TDP43 has properties of being an antimicrobial peptide. So you have to wonder, is this just nature's way of protecting us against infections, allowing us to get old enough to have babies? And then unfortunately, what's protective in youth can be detrimental in old age, and there's no evolutionary pressure for that not to occur because they already have the babies. There's also, which we should talk about, a very strong link with herpes simplex viruses and dementia. That's been really shown very clearly now. There's always been like a association with serologies and dementia. And there are a couple of studies. The most recent one that I read that I thought was really compelling was a study of people who had cold sores like at least 3 times a year, and they treated them with different lengths of anti-cold sore medicine. And the ones that got up to 1 month of these things like Valtrex or acyclovir had a 50% less rate of dementia in the following years than the untreated group. And then the people that got up to 6 months of these same medicines had about a 90% reduction of dementia. And it was a big group of people. Study was done in Asia. And I think that it's a real finding. I mean, so they have shown in the test tube, they make these little miniature brains in the test tube now, like just a collection of nerve cells that actually function as a mini brain. And they've infected them with herpes simplex and showed how it produces Alzheimer's changes in the brain. So the data, it's really, incontrovertible, in my opinion, about herpes simplex. Anything that has Lyme in the sentence, though, is instantly going to be met with controversy and arguments and everything else. I don't think anybody's going to argue about the herpes simplex data. It's very, very strong. I think the Lyme data is pretty strong too, but they're going to continue to fight about that probably for the next 10 years.
That was my question. So in terms of research on Lyme and other tick-borne pathogens and their contribution to the neurodegenerative diseases.
I think it's strong, but I also think that from our experience, neurodegenerative illness is probably the hardest group to help get better, and really relatively low response rates, just antibiotics by themselves, like 15%, very similar to the ALS group and very similar to the primary progressive, even though that's not technically neurodegenerative, they have a similarly low response rate. And, all the puzzles are certainly not worked out, but I do think that for dementia type illnesses, we should be expanding our scope. I was very interested in this guy, Dr. Shia Fradi's work on hyperbaric, because he has this kind of little twist on hyperbaric where they do hyperbaric and then they have them breathe room air, and then hyperbaric and then room air, blah, 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 up and down, up and down. And that shifting from super oxygenation down to room air tricks the brain into thinking it's hypoxic, which means not enough oxygen, even though it's room air. And hypoxia is a very strong trigger for having the nerves regrow. It's like a nerve growth signal. And I just think that a combination of events is going to be required to reverse some of these really severe cases. And, things like stem cells is kind of like the Wild West, but responsible research has to be done in these fields. Right now, it's kind of, at least in the Northeast, it's very much limited to using them for joints, but I have, case reports across my desk all the time of doctors who tell me they've, so-and-so family member has responded to, stem cell application, like intranasally and this and that. So, because there's a cribriform, plate in the nose, and things get right into the brain through there. And that's why COVID can get in the brain so easily through that plate there. I don't think antibiotics are enough for neurodegenerative. I wish they were. That's my statement there.
And in your practice, people have seen dozens of doctors. It's been many years usually before they find you. What are some of the presentations that have the most success rate? I know you have a really high treatment success rate.
Fibromyalgia is the easiest. Chronic fatigue is such a heterogeneous condition because, you'd find some patients that get diagnosed with chronic fatigue syndrome and they're really functional, and others are completely bedbound. And this whole spectrum, and it's not just one infection, chronic fatigue syndrome and ME. I think that it's a span. So some of these patients that are very severely affected are kind of difficult to get better, but we've gotten them better as well. But fibromyalgia is a more uniform base usually, and they usually respond very easily. Relapsing remitting MS is a favorite of mine. Like, I have personal experiences with this. I have friends that have had relapsing MS and been able to, fortunately, be instrumental in getting them better. And you would think that the rheumatic syndromes would be so easy to treat. They can be stubborn, they're frequently caused by Bartonella more than they are Lyme. And Bartonella can be a tough one to treat. Like, when I was getting treated, like I said, I failed so many antibiotics. People would say to me, how come you continued? And I'd say, because the antibiotics flared me up, they made me feel worse, and I was getting reactions to them. But the rheumatologist described those reactions as not working, and that's where we got to butt heads. And I was like, well, if they weren't working at all, it would be like a swing and a miss. So some rheumatology presentations, we get better really easily, and others can be stubborn, like mine was. Yeah, so some conditions in medicine don't have a name, and we see some of these patients that don't have, nobody can describe it. Nobody can diagnose what they have, I would say that it's a rewarding, job to be able to get people better when they've gone and they can't get better elsewhere. Yeah.
When people come into you with an autoimmune diagnosis and they've been on immunosuppressants and they're helping with the symptoms,
Mm-hmm.
how do you decide the pros and the cons about whether to take them off of those things to see if those immune suppressants are allowing an underlying infection to be more rampant?
I don't take them off. I mean, I would never, like, I always hate when I'm treating a patient and the patient goes to the rheumatologist tells the patient to go off the doxy, let's say. Like, I would never tell the patient who's seeing the rheumatologist to go off the Enbrel. I just don't do it. I don't want to be that arrogant guy who's like, I don't tell my patients what to do. I explain and educate. And I actually don't think it's a good idea to go off immune suppressants and onto antimicrobials. It's actually a really bad idea because you're going to get a really big rebound from going off. What I do is when we find evidence of infection that we can treat, we start treating. The immunosuppressants tend to minimize the Herxheimer's, so it's actually a more gentle process for the patient anyway. People who are immune suppressed, especially that have a history of steroids, are more likely to get actually spontaneous pancreatitis as well as pancreatitis during Herxheimer reactions, which no one seems to, it's not like a commonly discussed topic, but that is one big risk of immunosuppressants, that people during Herxheimer's develop pancreatitis. And so we educated them about that. And what usually happens, like I have a guy now, he's diagnosed with rheumatoid arthritis, nice guy, I just saw him like last week. And he's on methotrexate before he saw me. And he had tried unsuccessfully before he saw me to go down by 1/3 and he couldn't. And he had to go back up to the full dose. And then he went and he had a COVID booster. And for that, he had to be off the methotrexate. And he went off it completely. And he didn't notice a recurrence of symptoms. And he went back to the methotrexate because he felt more comfortable being on it than not, and thought the symptoms would come back. But it was a nice kind of example that as he continued to get treated, and I pointed out to him that, look, that was a test. You know that for X amount of time, you can go off methotrexate and feel well. And maybe as you feel more comfortable, I would never push. I'd say, methotrexate's a known carcinogen. It's something that damages the liver in a way that doctors can't really test easily for, because it doesn't actually raise liver enzymes that much. The liver is like a tree. You have like the branches and the leaves. And if you take like a statin drug and you get liver enzymes go up, that just damages the leaves and they grow back just fine. Whereas if you take methotrexate, it kind of damages the branches and they get scarred liver. And it works on the same way as like other chemotherapy drugs and alcohol, where it scars the liver, so it can't make the cells that the body needs. So methotrexate is very deceiving because you don't see big increases in liver functions, but you can get fibrosis from it without having a really scary looking blood test. So I explain all these things to my patients. When patients, we take a lot of time with patients. We schedule patients for 2 hours and, frequently go over that. And it's a lot of education. I just want my patients to feel empowered to make a good decision for themselves, but I'm not going to be the person or the doctor to say, do this. Sometimes they're like, you're the doctor, tell me what to do. You went to med school. And I'm like, well, they didn't teach me this in med school. So, we're kind of on an even playing field. I just explain everything. And I think we make a good decision together, but I don't tell people what to do because I wouldn't want some doctor telling me what to do.
How do you think we could get more doctors thinking like you and thinking about the root cause of chronic diseases?
I think it starts with med school. I mean, think about how doctors are trained, especially in residency. You're deprived of sleep and you're told the same thing over and over. I mean, I hate to say this, but it's very cultish. Isn't that how they brainwash people in cults and things? They're sleep deprived and they're told the same thing over and over. I think that there should be more classes on ways to encourage kind of a nimble mechanism of thought, like how to solve problems that does not involve memorization. And we do this, it's not like we don't do it in medicine. It's just that I could tell you for sure, after having gone through Wharton and having gone through med school, it was a stark contrast in how it was. Like, Wharton was just like a big IQ test. And then med school was mostly memorization. That's how I always explain it to people. And I think that should change. I just do. I think that doctors, though, are so rushed. If you're seeing, dozens of patients in a single day, they follow guidelines because it's all geared toward expediency and everybody has to fit into the same, round peg in the round hole. And then when you get a square peg, you're like, I have no idea what to do with this person. And then you end up sending them out So primary care doctors send out to all the different specialists, and all the different specialists are so siloed that they only see and look at what their specialty is. And then people fall through the cracks like crazy. So yeah, I think med school training is imperative.
In terms of your own thinking outside the box, you're working on some research. I know the Bay Area Lyme Foundation granted you an Emerging Leader Award. And what is that research that you guys were doing over with Neil Spector before he passed away at Duke University?
We're doing with Neil, then we transferred to a private company, and then we transferred over to researchers at Stanford. And it's working on a novel antimicrobial. It's something with a nanoparticle delivery system, and it's designed to work against resistant infections. And the goal is that it can work against Lyme and Bartonella intracellularly inside white blood cells. So we're trying to prove that, and that's the goal of the work in the study.
And in terms of herbals and natural therapeutics, do you use those for your patients as well?
We do. It's so weird because when I came back to practice, people sometimes don't tell you to your face, but I heard afterwards when I started talking about some herbals that I was like the one Lyme doctor that didn't believe herbals worked, because I had this reputation of being anti-herbal, and I feel badly about that. But you don't think you're going to be like influenced by where you train, but it was so anti-herbal where I did my training, and like the herbs, bull crap. They have a really vital role. When I was sick, I did end up taking every herb into the sun, and really none of them helped me. And then I took one, and it completely changed my life. And I had a huge Herxheimer on it, and I was like, oh, that's how it's supposed to work. So I do think it's a lot of trial and error, like it is with antibiotics. But we use herbs in the practice, but we're very diligent about it, because the flip side of the coin is that it's not part of the business model. Like I've been to a lot of doctors where they have to sell herbs, or their functional practice doesn't work, I think. And I would go to doctors with, I'd buy the 5 herbs. I go back to them and say it didn't work. And they say, okay, stay on those and take 5 more. And I'd be like, wait a second, that type of thing. So what we do is when we start herbals, we separate it out from other antibiotics to see if there's like a single agent activity from the herbal, and look for Herxheimers on the herbs, and really just tease out like build an army, find out what is working for each patient, what is not, and don't have patients on stuff that's a waste of money and time. And even if it's herbal, even if it's safe, whatever, if it's a waste of money, I always put everything into like, how many toaster ovens can I buy with that? Like if the herbs come out to $100 a month, it's we can use that money for a different herbal if you want to try an herbal program. So I keep the herbs on a tight leash, I guess is what I'm trying to say, but we do use herbals. One of my favorite supplements is monolaurin, and monolaurin was the last like supplement type of thing that really made the big difference for me. And that got me like really mostly over the hump there.
And in your book, you also talk about DNRS and mindfulness and meditation, and how mind connects to the body and chronic illness. Do you want to speak a little bit about that?
Yeah, and trauma therapy too. I mean, DNRS is great. It just takes a really long time. It's a big time commitment. Whereas with trauma therapy, EMDR, for me was very, very rapid. I did it twice. I didn't even put it in the book because we're not supposed to recommend how I did it the first time. But the first time, I was skeptical. And Dana had done it, and she puts her experience in the book, and I don't put my first experience in the book. But my first experience with the MDR was that when I came back to practice, people were asking me how I was. I couldn't talk about it because I started crying, and people would say, "How are you?" I'm like in 2 seconds, and I'm not like a classy crier. It always involves snot and ugly crying and stuff like that. So it was very unprofessional look, and I realized I got to do something. So I did the EMDR on YouTube. I did self-administered EMDR, and I felt something the very first session, 20 minutes, I felt different. I did 3 sessions in one night. It took me an hour. The next day, because it was every day, people were asking me how I was, and I told them my story, and I didn't break down. I was like amazed, and I could not believe that happened. And then I went on, we went on to write the book, and I was able to do it without being a basket case. And then when my brother died, I lost it. And I did EMDR on YouTube. It didn't do anything. And I went to a psychologist on telemed, and 3 sessions of EMDR, and I'm back to my own self. And It's really, I don't know why for me it works so well, but I can tell you it's absolutely transformational, and it's durable, drug-free, and fast. And it's a standard therapy for trauma. And I recommend it highly to my patients. In terms of DNRS, I recommend that as well. And in terms of mindfulness, I recommend all these things.
In terms of diet and lifestyle exercise, what's your take on that for your chronic illness patients?
For exercise, I tell my patients don't give in to the feast or famine thing, because the symptoms are so highly fluctuating. People get good and bad days, and they tend to overdo on the good days and underdo on the bad days. And I advise moderation, like just to keep, it's like the tortoise wins the race, just a mild to moderate exercise, and to do something every day. In terms of diet, I mean, people respond different to different diets. I mean, personally, I'm vegetarian, I'm not a vegan. Some of my patients really feel better with keto type diets, and I'm not anti-keto. I don't know that there's one universal diet. Some of my patients have tried several. Some people do diets for, their GI tract with like an anti-inflammatory diet and a FODMAP diet and a gluten-free diet. And, I can just tell you that when I was at my sickest, it didn't matter what I ate. Any type of food made me feel like I was going to pass out. I would eat and I'd become like I couldn't stand. So, and then when I got better, I kind of realized it was mainly carb related. And I have had a lot of patients like that say that food of any kind. And then I've had some patients say it's certain foods where they have like actual food allergies. And then I've had some patients where they have gluten. So I don't think it's a one size all, fits all approach. Really.
What do you see with these stealth pathogens causing psychiatric illness? We know that inflammation in the brain can cause psychiatric illness that people generally just write off as, that's the way your brain was developed, but that it's actually an infection in a certain percentage of these cases.
Yeah, it's very common in my patients. It's I would say probably like 60% of my patients have psychiatric manifestations as well as physical manifestations. I've seen some cases where it's purely psychiatric, it's really called neuropsychiatric because it's neurologic etiology. And, it's a special kind of, warning and a special kind of consent that I give to patients with psychiatric features. I said, look, if we give you antibiotic X and your elbow pain flares up, most people can tolerate that and kind of get through it and complete treatment. If depression flares up and it becomes suicidal, or anxiety flares up and becomes non-functional, it's a different story. A lot of people can't get through that. And we have to make sure that the support systems are in place and that we have active communication so we can help them out during that time. But yeah, we see, it's clearly kind of infection/chemical based in so many patients because they flare up with psychiatric Herxheimer's. The other side of the coin is that people get traumatized, that people get reactive depression also, that people feel abandoned by not just like sometimes loved ones and the healthcare system, but they're abandoned and betrayed by their own bodies. The trauma is like so multi-level trauma that we have to rebuild. But yeah, I think that inflammation of the brain is a key driver of psychiatric illness. And it's always been counterintuitive to me why some psychiatrists have come on board with that, but it's always been counterintuitive why they haven't figured this out earlier, because it's the same brain that causes like numbness in your hand or numbness in the part of the brain that causes joy, and then you get depression. Like they are two sides of the same coin, and I don't know why they're treated by most doctors to be so distinct and different.
Yeah, I'm glad that Brian Fallon at Columbia, he's a psychiatrist there who has a research group based on tick-borne diseases and the effects on, the whole body, but definitely the psychiatric side. So maybe that will lend some validity in the psychiatric world to the infectious origins of psychiatric diseases.
Yeah, I hope so.
Is there anything else you'd like our viewers and listeners to know before we sign off?
Just that chronic illness isn't hopeless. It just sucks. And there's a big difference between hopeless and sucks. I know what it's like to feel hopeless. I was hopeless. I really thought that nobody could help me. And it was, I got better it was a chance kind of a thing. I don't know if I put this in, I think I put it in the book, but how I figured it out was I got a chance email from somebody asking for help. And this person saying like, can you help my friend's daughter? She's like in the ICU and she's got a really bad situation. She tests positive for brucellosis. Nobody knows what brucella is. Do you know what that is? And I looked it up, and it was every symptom I had. And at that point, I couldn't lift my arms against gravity at all. So I had to like pull my fingers on the keyboard up to look up brucellosis for this really a stranger. And I was like, if I can't do anything for myself, I may as well try and help someone, you know. And in doing that and trying to do that little bit of research for this person, that's when I was like, holy crap, I think I have brucellosis. And then I tailored my treatment toward that. I sent my blood out to a brucella research center in Europe that were really nice to me. And it took 2 months to get the results back. I started to improve and get better. And they sent me back. They had the most advanced test for brucella in the whole world. I said, congratulations, Dr. Phillips, not a trace of brucellosis in you. You never had brucella. And there's no possibility of it. And I was like, okay, but Bartonella and brucella, close cousins. I'm getting better. I'm not going to stop, you know, the treatment that I took. So the other take home message is that we have literally yet to discover, it's been shown in medical studies, 99.999% of the microbes yet to be discovered are still out there. And they know that from looking at the diversity of the genetics of life that we already know, and they just extrapolate it out. It's a really accurate mathematical way of figuring out how much expected diversity of life there is on the planet. We have yet to discover the vast majority of it. So when people say like, oh, we've learned everything about Lyme, we've learned everything about Bartonella, you haven't learned anything about anything. You know, we're really in the infancy of these. This book is like chapter 1, and for people to speak with certainty about topics that are, you know, in a constant state of flux is silly. And that's why I want people to have faith in their own experience and to follow their gut.
In your book, you talk about the different species of Borrelia that are being discovered and the different tick-borne pathogens that we're just discovering. Do you want to talk a little bit about that?
They discover new ones every day. They discover them every day. It's and many don't meet the genetics for Lyme. But if they do everything that Lyme does, and they never test positive on a Lyme test, like, what do you call that? Okay, so it's not Lyme disease. Who cares? It arose by any other name. This is where it gets so silly. So somebody has, I mean, Miyamoto is pretty well studied at this point. In Connecticut, it's 40% as common as Lyme. We have tests for it now and everything else. But most primary care doctors don't check for it. So even though it's kind of made mainstream, it's trickled down to mainstream news, I'm finding when people come in, you know, primary care doctors are sending their patients over, and all they're doing is checking for Lyme. They're not checking for the other ones. It's very hard to get checked for the other Borrelia, like Borrelia mayinae is, you know, only a couple of labs will even check for it. There are many where there are no tests. And how do you know if you have these pathogens if there's no available tests for these Borrelia species? This is why it's, like I said, this is what kind of irks me sometimes when doctors, there was a famous doctor that I won't name, because I don't like him. And he had said 20 years ago that everything about Lyme has already been discovered that we'll ever know about this illness. And then 10 years later, they figured out they couldn't kill Lyme in the test tube with the antibiotics that purported to, you know, to cure Lyme disease patients. That's a big oops, you know. So I do think that when patients encounter a doctor that is not humble before the enormity of medicine, they should run the other way. That's my big advice. Just run as fast as your legs can take you to a doctor who realizes that, you know, we're still learning.
Thank you so much for joining us on the Ticktective video and podcast series. I highly recommend that everybody go out and get your copy of Chronic. The COVID chapter is downloadable because this came out right before COVID came out. And Dr. Phillips has a Facebook channel with Dana Parrish, and you have your website and Twitter.
And it's in a second printing now, actually, the hardcover. So the second printing does have the COVID chapter, and the paperback is coming out in about 2 weeks. And that has the COVID chapter as well.
Great. Well, thank you so much for doing this. This is a great service. I love
Thank you.
How brave you guys are in speaking to the things that nobody else is really being bold enough to speak about. So thank you, and thanks for doing all your good work.
My pleasure. Thank you for having me.
Thank you for joining us for this episode of the Ticktective podcast and video series, a program of the Bay Area Lyme Foundation. You can find out more or donate at bayarealyme.org.